Hi, everybody. Thanks for having me here. I'm going to talk about the use of focused ultrasound for cancers for which there is effective immune therapy, but where there's a benefit in the combination. So I think this follows nicely on the talk you just heard about the immunologic effects or potential immunologic effects of focused ultrasound. I am newer at this. This is something we're just getting started, and the clinical trial that I'll mention, and it's really because of the support of the Focused Ultrasound Foundation leading to development of really new approaches. So the immune system has become a huge focus for the treatment of cancer in recent years, as it's become clear that for cancers to survive, for them to evolve and survive, they have to have figured out ways to evade the immune system. And so you can see here, this is just a picture under a microscope of a cancer cell in the center and killer T cells, immune cells that can recognize and kill cancer. And so in the best circumstances, we know that these immune cells can recognize cancer cells and kill them, but they don't do that effectively in most people that have growing cancer. And so the goals of immune therapy are to induce an immune response to cancer where there may not already be one, or to overcome the suppression of the immune response that the cancer may have induced. And if you think about it this way, this is sort of an analogy on the left-hand side. If you're thinking about trying to identify a criminal, so in our bodies, a cancer is a criminal, you need to figure out what it looks like. And unfortunately, sometimes criminals, like here, wear a mask, and that hides the features that might help you identify what it is. So cancers also can mask themselves to prevent the immune system from seeing them, because there are some features that ideally we can identify on them, and we call those antigens. These are molecules on the surface of the cell. So like you might describe the criminal you saw is wearing a green mask or wearing a black hat, but the cancer cell will have certain features that the immune system can see, but we need to train it to recognize those. And it's interesting because I think most of us were kind of raised to think the immune system recognizes what is ourself and says that's okay, and it recognizes things that are foreign to say that's what it should eradicate. So a bacterium or a virus is foreign, and we do recognize that. But it's become clear from the work of Polly Matzinger about 20 years ago that a lot of what's really important for the immune system is to recognize danger signals. So it recognizes things that are shown to it, if you will, in the setting of a danger signal, like focused ultrasound creates inside the tumor. The concept of the immune system recognizing cancer is becoming very clear, as I say, and we understand what has been described on the right-hand side of the figure as a cancer immunity cycle, which is described sort of briefly here. If you look on the bottom of that, number one, if a cancer cell dies, it releases antigens, these things that can be recognized by the immune system, and they will then get presented to the immune system by an effective antigen-presenting cell, number two, going up, and then they prime immune cells or T cells. Those can then travel to the tumor and then invade the tumor and recognize the cancer cells and kill the cancer, which then releases more antigens. So in the ideal world, this is what happens. This cycle helps promote the immune response. But the problem is that in people with cancer, something is going wrong at one or many of those steps. And what's listed here under each of these titles is different treatments, like under number 3, anti-CTLA-4 is an antibody that can be used to help support priming. And so there are a lot of therapies that may help support individual or reactivation of certain parts of this immune process. Focused ultrasound has the appeal of potentially interacting at least 3 of these steps, to help kill the cancer cells in number 7, to help release the cancer antigens, and then to help activate the immune cells that present the antigen to the immune system, which are called dendritic cells. So there's a lot of reason to be optimistic about the role of focused ultrasound in cancer therapy. And if we think about the clinical situations, the patients that we deal with, melanoma, which is the main focus of what I do and the primary focus of this trial that we're going to do, although it includes some other cancers. Melanoma has been the most exciting area really for the developments of new immune therapies over the past few years. And so we now can offer treatments that can help cure people. However, there's still a long way to go. And so if you take 5 patients here, each who have a tumor, and you treat them with what we consider the best available immune therapy now, which is a PD-1 antibody with or without CTLA-4 blockade, one of those patients you'd expect to have complete responsive tumor. Maybe not quite 1%. So, I mean, not 1, so 10 or 20% will have a complete eradication. And then another 40%, 30 to 40% may have a partial response, meaning the tumors shrink. They're smaller than they were, but they're still there. And then another patient will have really just stable disease. and another patient will have growth of disease, for a total of about 40 or 50% of people that really don't benefit from this best available therapy. And then even for those patients who have benefited, another 20% or so will have recurrence of disease despite an initial response. We call that secondary resistance to the treatment. So the toxicity can limit treatments. The treatments don't work for everybody. Retreatment can be feasible for some, but not everybody. So there's really an urgent need for treatments with low toxicity that can be used to enhance benefit in these patients despite or in addition to already exciting therapy. And focused ultrasound, as you've already heard, can focus energy directly at a tumor and either eradicate all of it or part of it. You've already heard talks about several different kinds of tumors and malignant cancers that have been treated or are being treated in this great talks you've already heard. But it's still not standard of care, standard therapy for cancer control. And one of the things that I think may not have been brought up fully yet is that when you treat with focused ultrasound, there's going to be, say you have a tumor target here, there's going to be a zone that you want to ablate and totally destroy with the focused ultrasound. And we can call that a primary ablation zone, where you may expect, with at least certain kinds of the focused ultrasound treatment, direct destruction of all that tumor, coagulative necrosis, and some immunologic changes with really high temperatures. But then there's also a zone around that that's not getting the full energy, but some decreased energy, the secondary zone, where you can have a lower heat stress, slower cell death, and even a more supportive environment of an immunologic response with a temperature of about 40 degrees centigrade. And so heating the tumors rapidly to cell-lethal temperatures can change the tumor microenvironment to create a danger signal to help activate the immune system, can change the vasculature and the lymphatics, can induce tumor cell death, as we've talked about, and there's increasing evidence of activation of the anti-tumor immune response so that there can be benefit beyond just the treated tumors, which you've just heard about in that very nice talk in pancreatic cancer. Some work that's been done here at the University of Virginia by Kumari, Andarawewa, and Patrick Dillon, unpublished, have shown that in mice with melanoma, where you inject two different tumors and treat one of them with ultrasound, not only will the treated tumor shrink, but also the tumor that wasn't treated will shrink. So it provides strong evidence that in an experimental setting, you can induce a response that's not just the direct effect, but a systemic effect, and almost certainly is immunologic in its method. So in trying to understand whether this translates into humans, again, you've heard some talks that already address this, but also there have been a number of studies here in breast cancer that if you evaluate tumor before treatment with focused ultrasound and then after, the brown stained cells are the killer T cells, killer immune cells, and you can see increasing numbers of them in the tumor after treatment with focused ultrasound, suggesting immune activation. And there have been a lot of other studies, which we won't go into in great detail, but showing that in humans, this focused ultrasound can cause cell death in the tumor, increasing capillary leakiness to allow immune cells to be delivered. It can alter the immune microenvironment and shrink the tumors beyond the ones that are treated with focused ultrasound. So we hope that we can bolster and sustain these responses for benefit, in combination of this approach with an already active immune therapy may be a very appealing approach to help overcome immune tolerance and increase greater activation of dendritic cells and T cells. So the trial that we're in the process of writing is one for patients for whom immune therapy with this PD-1 antibody, which is already FDA approved, has been tried, but has not been successful yet, and where there may be a small benefit in continuing that treatment alone, but where we want to be able to then activate the immune response with focused ultrasound to enhance the overall response with focused ultrasound. It will also be for people who have diseases that we know have very low rates of response to PD-1 antibody alone, again, to try to enhance that response. And again, the goal is really to identify novel or combination therapies that can be used to enhance the clinical benefit to individual patients. And I can tell you, like, I've been operating this week, and there's a patient that I've seen recently who had, it was a young woman, like in her 40s, who had melanoma that recurred in lymph nodes in her groin, and then had surgery, and then recurred later higher up, lymph nodes in the pelvis, and had this PD-1 antibody, and the tumors didn't shrink. So we've taken her to surgery to take those out. But this is a patient where there's almost certain confidence that she's going to recur again. And she's already failed this best therapy we have available. So having this trial available, which should be open in the next few months, will be something that she can be eligible for to help advance her response and clinical benefit. So yeah, this trial will be evaluating, as I say, focused ultrasound with and without checkpoint blockade antibodies, and will assess the safety of that combination, will help us understand the effect of focused ultrasound in the tumors, because part of the study is, that we're excited about is that we'll be biopsying the tumors before treatment and after focused ultrasound, so we understand not just the clinical outcome, but the biology in the tumor that we induce. And that's appealing to do in this setting because these are cancers that tend to be on the surface where we can do biopsies. And again, we'll have preliminary data on the clinical activity. And again, this protocol, we've already drafted it, and we just have to get it finalized and through the regulatory approvals. And again, it's funded because of the Focused Ultrasound Foundation. Thank you very much.